Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and today we're going to go ahead and go through our discussion on hyperlipidemia. We're doing this as part of our advanced pharmacology lecture series, which is one of the three core courses for nurse practitioner education. So let's go ahead and let's begin with understanding how we diagnose a patient with hyperlipidemia and how we make a decision on whether or not to start them on medication. So first of all, we have to understand, what is cholesterol? Cholesterol is something that is used by our cells, and most of the cholesterol that we're going to discuss for our purposes is going to be attached to either LDL, low density lipoprotein, or HDL, high density lipoprotein. In the normal course of events, these cholesterols are produced in the liver, and then they are taken to the cells to be used. However, in a case where there is an elevated cholesterol level in the body, those cholesterols end up getting used by endothelial cells along our blood vessels and basically become part of our blood vessels, developing what we call plaque and what is diagnosed as atherosclerosis, which is one component of cardiovascular disease. So now that we understand a little bit about the pathophysiology of cholesterol, let's start to discuss how we diagnose a patient. Let's begin with discussing a lipid panel. A lipid panel is something that you're going to order very often. And depending what guideline you look at what age we want to start screening our patients and at what interval. But generally speaking, this is something that patients are going to get screened every year on their annual physical examination. So a lipid panel is going to give us a few different numbers, and we're going to focus on four of them. You have your total cholesterol, your triglycerides, your LDL, and your HDL. I want to clarify one point. You may have heard a term VLDL, or very low density lipoprotein. Nearly all VLDL in our body is actually triglycerides. So we're going to use those two terms interchangeably, but triglycerides are a component of VLDL. Nearly all VLDL is triglycerides. So total cholesterol, we want that to be under 200, triglycerides under 150, LDL under 100. You may see some guidelines that say your LDL should actually be under 70 in a patient that has diabetes or existing cardiovascular disease. And finally, we have HDL. That is what's commonly referred to as the good cholesterol. And that we want in females for it to be over 50 and in males for it to be over 40. Now, a few things I want to point out to move us a little bit past the RN level and up to the provider level with understanding these numbers. Again, I know this is an advanced pharmacology course, but this is all still fair game in your course. So total cholesterol, depending on the guideline, you may see 200, 220, 230 as still being considered high or normal or borderline elevated. Once we get up to about 289, it's pretty much universally considered that that is a very high total cholesterol level. LDL, a little bit similar. 100 to 130 is where most textbooks say is the normal. Most labs use this number. I got these numbers from Up to Date. Now, an LDL that is over 189 is considered pretty universally as being very high. Triglycerides are a little bit different. Even though we want triglycerides to be under 150, we don't say it's very high until it gets up in the hundreds, 400, 500 or more is where most guidelines would go ahead and consider your triglycerides to be very high. And triglycerides can run really high. They can get over 1,000. The higher a patient's HDL or good cholesterol it is, the lower their chance of developing the adverse effects of hyperlipidemia. Now, ASCVD, or atherosclerotic cardiovascular disease risk calculator, is a calculator that we input a bunch of information about the patient, their total cholesterol, their HDL, their blood pressure, their diabetes status, their smoking status, whether or not they're on medication for blood pressure. And this tool is used very, very commonly. And the end result of this tool is two things. Once you put all the information in, it's going to tell you what is the patient's 10-year risk factor. That means, statistically speaking, and this is based, to my understanding, on millions of data points, what is the patient's statistical chance of having a major adverse cardiac event, in other words, a heart attack or a stroke, within the next 10 years. And if it's above a certain threshold, I believe 7.5%, we are going to go ahead and we are going to suggest that the patient go on a statin. If you use this calculator, and this is a universal tool. If you use the ASCVD risk calculator, depending what platform you're using on, it will actually have the guidelines incorporated into it. For example, MD Calc, it'll have the guidelines incorporated into it. And as soon as you put that information in, it will tell you whether the patient should be on a low density or a low intensity statin, high intensity, etc. So for the diagnosis of cardiovascular disease, we need to know the lipid panel. We need to know what an ASCVD risk calculator is. Once we've made the diagnosis of a patient that they have hyperlipidemia or dyslipidemia, we're going to work on non-pharmacological interventions, also known as lifestyle modifications, also known as therapeutic life changes, TLC, whatever terminology your university is using. So there's 4 major risk factors that we have. One is high blood pressure, so we want to work aggressively to get that under control. If you're familiar with the AHA's Life's Essential 8, those are 8 risk factors for developing cardiovascular disease. We want to work on all of them. Most of the textbooks will specify these 4. So these are the 4 that I listed: hypertension, smoking. You're a provider now, so we're not just going to educate them like we did as an RN on what to do for this. We're actually going to start to do something. We're going to put the patient on Chantix, which is varanzoline, or bupropion, Zyban. We're going to actually hopefully get this patient more aggressively into quitting their smoking. We definitely need to go back to our RN roots and educate our patients on diet and exercise. AHA recommendation is at least 150 minutes per week of aerobic activity. And of course, we want to get them to reduce, not eliminate, but reduce their bad fats that they're having in their diet. Fried food is probably considered the worst thing. So fast food, things like that, if we can get them away from that and at least make incremental changes, we can make a big difference. Now, metabolic syndrome is something that you're definitely going to hear in your education. It may not be in the advanced pharmacology course, but I am going to throw it in here because you can't really discuss hyperlipidemia without discussing metabolic syndrome. So metabolic syndrome is an actual diagnosis. It has its own ICD-10 code, and it's diagnosed when a patient has 3 or more of the following 5 characteristics. What are they? A waist circumference that is greater than 40 in men or 35 in women, a blood pressure that's greater than 130 over 85, a fasting triglycerides that's over normal, a fasting HDL that's below normal, or a fasting blood glucose that is over 100. A lot of people can have 1 or more of these characteristics. If someone has 3 or more of them, they have metabolic syndrome. And the significance of this is that a patient that has metabolic syndrome, basically, they are knocking on the door of diabetes and cardiovascular disease. If they have 3 or more of these and they have metabolic syndrome, they're pretty much already there. If not already there, then they are about to be diagnosed with diabetes and cardiovascular disease. And this is something you can educate your patients on and explain to them. You may not have diabetes or cardiovascular disease today, but we know from evidence that if you have 3 or more of these, you're about to. So today's the day to start making those lifestyle modifications. So now let's go on and let's talk about pharmacology in terms of hyperlipidemia. Before we get into that, since you're still here watching, hopefully enjoying and learning from this lecture series, please go ahead and subscribe to keep this channel going. So the first line medication universally for a patient with hyperlipidemia are going to be what we refer to as statins, which are technically called the HMG-CoA reductase inhibitors. So throughout the discussion that we're about to have of the different medications for the treatment of hyperlipidemia, there's 2 basic ways that we're going to use to lower a patient's cholesterol. The primary method is by increasing LDL receptors. The more LDL receptors a patient has in their body, the more the body can get rid of LDL in our blood. Remember what we said in the first few minutes of this lecture. LDL, a high level of LDL in our blood, causes the LDL to get taken in by the endothelial cells of our blood vessels. It gets built into the wall, and then it becomes atherosclerosis. We want to avoid that, so we want to lower a patient's LDL. Throughout all of our pharmacology treatment for a patient, LDL is the number we're using to monitor the progression of our treatment and if we're hitting our goals. So the statins are a very common medication that we use. In fact, it's the first line agent. The mechanism of action is that by inhibiting HMG-CoA reductase, that's an enzyme, by inhibiting that enzyme, the body develops more LDL receptors. It's pretty complicated for exactly how it does, and I'm not going to get into the nitty-gritty of it. I don't think that you really get tested on the exact mechanisms of this, but understand that it inhibits HMG-CoA reductase. That's an enzyme. By inhibiting that enzyme, the body increases the LDL receptors. By increasing the LDL receptors, more LDL gets processed versus sitting around in our bloodstream, getting built into our blood vessels and atherosclerosis. There are a lot of different statins. I listed 3 of them here. There's more. There's pravastatin and others, but these are the ones that I listed. Statins are broken down into 3 categories: high intensity, moderate intensity, and low intensity. And these are broken down by how much they can lower a patient's LDL. A high intensity statin is designed to lower a patient's LDL roughly 50%, 50 to 60%. So that means if someone comes in with a high LDL, let's say their LDL is 180, I could give them one drug and I could get it right down to 90 and they're already at their goal. And that's great. As opposed to, if you watch the hypertension lecture, we know that it takes multiple blood pressure medications to have such a major drop in a patient's blood pressure. Cholesterol, one pill can do it. Moderate intensity is categorized by that, and those medications are meant to bring the patient's LDL down roughly 30 to 50%, depending which one and the exact dose. And finally, a low intensity statin is going to lower a patient's cholesterol, their LDL, by roughly up to 30%. So what are we talking about? Well, there's only 2 medications that meet the qualification for high intensity, and that's atorvastatin and rosuvastatin, which is Lipitor and Crestor. Those are by far the 2 most commonly used statin medications. And these medications at the higher end of dosing, which in rosuvastatin is about 20 milligrams and atorvastatin is 40 to 80 milligrams, those can get that maximum amount of reduction in LDL up to around 50 or a little bit more % from where they were. Again, we're talking about the LDL level. Now, these medications will also lower your triglycerides, your VLDL, a little bit. And then we have the low and moderate intensity. Once we get into low and moderate, we do have more options for statins like pravastatin and others, versus high intensity, we only have atorvastatin and rosuvastatin. When we put a patient on this medication, first of all, because it's hepatotoxic, that means you're going to get a CMP pretty early on in your treatment before starting this medication, and that's something you're going to be monitoring. Obviously, you're going to have a lipid panel. Depending what guideline you look at, we're going to check their lipids either every month or every other month until we get their numbers down to where we want them, and then we could go to every 6 months or every year, depending what guideline you're using. But we do want to make sure that we're constantly keeping an eye on that. The adverse effects of statins are hepatotoxicity, myopathy, and it can actually cause new onset diabetes. Now, for myopathy, the most common presentation of this is muscle aches. So if a patient has that, you want to pretty intensively look into that, order some labs, and see exactly what's going on and check what's going on with the patient, because if left unattended or undiagnosed, that can lead to rhabdomyolysis. Now, not everyone is going to be able to tolerate this medication, either because they're developing that muscle aches or something else, in which case we would have to move on to another medication. It is very controversial right now on statin use in pregnancy. Statins for a long time were considered FDA category X, that they were teratogenic, could not be used in pregnancy, could not be used in a female of childbearing age, period. However, the FDA in 2021 recommended to the manufacturers of these medications that they go ahead and remove the contraindication of pregnancy and put it as a, I don't know the exact verbiage, but basically look at the risk versus benefit like we do in so many other cases. Because it had, this was done by reviewing all of the evidence in terms of how damaging it is to fetus and how damaging it is for a patient that needs a statin to suddenly come off of it. One other note about this class of drugs is that this may be used in our pediatric population. Pravastatin and most of these other statins are approved for adolescents. I believe the age cutoff for most of these is going to be around 10 years of age. Obviously, if you're prescribing that, you want to do it in consultation with a pediatric cardiologist to make that decision. But that's definitely an option that we're going to have. And unfortunately, we do have many, many children, especially here in the US, that do need to be on statin therapy for their hyperlipidemia. All right, let's go ahead and let's move on to the next class of drugs. Actually, two more points I want to make. One is that statins are available in combination with other medications, such as your lisinopril. So you will see that sometimes where a patient's taking their blood pressure medication mixed in with their cholesterol medication. So you do want to keep an eye out for that. And secondly, a lot of times patients that cannot achieve their full goal of their LDL on a statin can get an add-on medication, and that's what we're going to discuss next. So alternatives to statin therapy, and I want to really clarify, most of these drugs are not used as an alternative to statin. They're used as an add-on to statin. So the first one we're going to talk about is the bile acid sequestrants. Cholestyramine is the older one. Colesevelam is the newer one. These medications can reduce the LDL roughly 20%. So if let's say someone comes in with a LDL of 250, that's really high. We put them on max dose statin, 80 milligrams of atorvastatin. We get them down to about 120. They're still over where we want them. So we add on colesevelam, and now we could get them down under that 100 down to our goal. So how does this drug class work? Bile acid sequestrants, they bind to bile acid. Bile acid has a lot of cholesterol in it. By binding to that, they prevent the body from using that, thereby reducing the cholesterol synthesis that would occur from that cholesterol, forcing the body to use up more of the cholesterol that it already has. This medication does not have any systemic effects because it's not absorbed into our system. It stays in the GI tract. However, in the GI tract, it can have significant symptoms. Most commonly, by far, is going to be GI effects, the most common being constipation. For this, make sure you tell your patient you may need a stool softener, you may need to increase fiber, you may need to increase fluids, activity, something like that. Bile acid sequestrants are unique among these medications in that they can actually increase your VLDL or your triglycerides. So you want to be really careful, and this might not be a good option if a patient also has a really high triglyceride level. That would be this would be a poor choice to add on to this patient's treatment. The biggest issue that we see in putting a patient on a bile acid sequestrant is it interacts in the GI metabolism of many other medications. So for that reason, it cannot be taken at the same time as other medications. There's a list of exactly which ones. Play it safe and just tell your patient, take this medication either 2 to 4 hours before or an hour or two after taking any other medications. Definitely don't take it at the same time. Again, by far, this is most commonly used as an add-on medication. It would be pretty unusual today to use this as monotherapy. Again, all the same stuff. You're going to monitor their lipid panels. You're going to keep ordering it every 30 or 60 or 90 days until you get their number stabilized. And then you're going to go ahead and go to your every 6 months or every year. Then we have a few other medications to discuss. We have the fibrates, and there's 2 of them I listed here, gemfibrozole and fenofibrates. And these medications lower your triglycerides. They don't affect your LDL, but they do lower your triglycerides. Because of their mechanism of action, they can cause gallstones, they can cause myopathy and liver injuries. So those are all things that we want to assess the patient for. Obviously, when you see liver injury, you know that's hepatotoxicity. You have to check their AST, ALT before putting them on it. And each of these medications, again, has a specific purpose. This one can reduce your VLDL by around roughly 50%. I wouldn't expect you to have to go too deep into the mechanism of action of this one. The next drug that we have is ezetimibe. Ezetimibe works a little bit differently than the other ones. This one, again, is most commonly used as an add-on drug. And this one can also reduce the LDL by roughly the same 20%. It's tolerated a little bit better. It does have some side effects that would most commonly be like sore throat, congestion, runny nose, things like that. But again, this is most commonly used as an add-on. I do believe it is approved as a monotherapy agent, but it's not very commonly used as that. Again, the mechanism of action here is it gets the body to increase the number of LDL receptors in order to get rid of the LDL cholesterol. And finally, we have the PCSK9 inhibitors. This is the newest class of drugs that are used for the treatment of hyperlipidemia. There are 2, actually, I believe there's a third today, but there's 2 main ones that are used in the United States. I hope I'm pronouncing these correctly, evolocumab and alirocumab, which is Repatha and Praluent. These two drugs, these are by injection only. You're going to dose these for your patients every 2 to 4 weeks, an injection. So it's not like they have to get it every day or even every week. So it is a valid option. The two common times where we use this, one is where we already put the patient on maximum statin and another drug, let's say colesevelam or ezetimibe being the more common one, and they're still not getting to their LDL goal. The other common place where we use this, probably even more common, is where a patient just doesn't tolerate a statin, whether it's because of allergies, whether it's because of myopathy, or whatever it may be where the patient does not tolerate it. Keep in mind, these do require prior authorizations. That's something your office is going to have to work with the insurance company when keep in mind when prescribing this. These are really expensive medications to pay out of pocket. It's hundreds of dollars a month. These are considered monoclonal antibody drugs, the MABs, the MABs. You may have heard of this or remember this from your RN education. That's a massive class of drugs with over 100 different medications. We use it for everything from COVID to asthma to reverse certain drug overdoses to treating hyperlipidemia. This medication is a highly effective medication. And in fact, some of the evidence suggests that this is going to eventually end up as possibly a first-line agent. But this does also reduce the LDL to the same level as a high-intensity statin to that 50-60%. The mechanism of action here, PCSK9, from our understanding thus far, is it ties up LDL receptors. So LDL receptors are not able to get rid of that LDL. PCSK9 inhibitors inhibit the PCSK9 from tying up that LDL receptor so that it allows the LDL receptor to get back to processing LDL and getting rid of it, which is our end goal. Here you have your references for this lecture. Please reach out to Bullet Point Nursing with any questions. Have a great day.